Good morning, and thank you for joining us for this Policy Interested Parties meeting. I'm Fatima Mirza, and I'm the Program Case Manager for the Medical Commission. This meeting is being recorded. The purpose of this meeting is to collaborate with interested parties such as public, association members, physicians, and physician assistants regarding our policies, guidance documents, and interpretive statements. The documents which will be discussed here today are available on the policy meetings page on our website, which is wmc.wa.gov. Attendees, if you would like to ask a question or speak, please use the raise hand function or the chat. When commenting, we request you avoid commenting on ongoing investigations or disciplinary cases. Please make sure your comments pertain to the agenda items. Are there any questions? Not seeing any. So with that, I'll pass it over to our policy manager, Khadija Chuketa. Thank you.
Thank you so much, Fatima, and good morning, everyone. Thank you all for joining us. So I'm going to take you through the documents that we have on our agenda. They're all guidance documents, and then they're due for our review. So the purpose of this meeting, as Fatima mentioned, is to get your ideas and also to collaborate with you on some of our documents that we have. Health. So I'm gonna give a little bit background on each of the documents and also open the floor if you have any comments or feedback or suggestions on the language. So the first one is practitioner health. So and also I'm gonna put this note there. We're gonna add the CCAs, that is the certified anesthetist assistants, because we're gonna start licensing them. So we will add that before the end of our review process on the documents. So the first one is practitioner health, and it's about when practitioners have the responsibility of undergoing certain evaluations as themselves, like their health evaluation throughout their careers, because we want to ensure that there is a safe practice of medicine. And these assessments should be individualized, and also they cover both the physical, the psychological, cognitive screening, and substance use aspect, and is tailored on their job specific demands. So the evaluations start after their certification or even after their postgraduate training without no certification. And we also have the suggested frequency by age. So as you see on the screen, start from when they're in 25 to 54, we want them to do this health evaluation screening from every 5 to 7 years. But if you are a practitioner that is living with a chronic condition or you have a disability, this evaluation can be increased like as you needed it based on your condition. So this is the full document. If you have any questions or you have any feedback or suggestions that you want us to make on this document, you can please raise your hand, or you can use the chat function on the screen. So the floor is open for anyone that have any suggestions or comments. Do you see any, Fatima?
No, I'm not seeing any.
Okay. Okay, so we'll move on to the next one then, since we don't have any comment on this one. So the next one we have is also a guidance document, and it's up for review. So it's about we provide guidelines to practitioners to support them, like when they have a little break on their practice. Let's say you given birth, or you want to take a break from practice, or you have a family member that you need to take care of, or you gave birth. So, but we give guidelines on how they can come back after taking this kind of breaks. So we have an interval of, if you take a break for 12 to 24 months, we encourage you to complete an informal reentry program. And if you take a break for more than 24 months, we also suggested that you complete a formal entry program that will include self-assessment, skills evaluation, and supervised practice. So this guideline highlights the importance of you planning ahead because these things can involve you working with qualified mentors and also addressing any health or substance use issues you may have, and also exploring the funding options because the funding solely depend on you as the practitioner. So we encourage you plan ahead if you want to come back to practice. So again, if you have any questions or you have any feedback or comments that you want us to be aware of about this document, you can raise your hand or you can use the chat function. The floor is open.
Khadija, too, we have comments from Dr. Bundy that I'll pull up now.
Okay. Okay, so Dr. Bundy suggested that, can you make a little bit bigger?
Is that okay?
Yeah, that's fine. So you can scroll down. Okay, so he suggested that if you are a practitioner and you have any mental health issue, either psychiatric or any substance use disorders, you can contact the Washington Medical Health Program, and then they will give you recommendations on how to clear out, on how to come back to practice after that break. So that's the recommendation that he give on this document. And then we're gonna push that to our policy committee meeting and get their feedback on that. So if you have any other comments, you can raise your hand or use the chat function as well. Okay, we have a hand. Please go ahead.
Yeah, just a clarification. This is Yanning Yu. I know many of you.
Mm.
Uh, is this the one? Since I cannot see screen very well, is this the policy for reentry after suspension, or is it a different one?
It's a different one. We're gonna talk about that right next.
Okay, all right. Sorry.
No
Now,
problem. No problem. Do we have any? Seems like there's no hand, so we can move to the next one. And that is the re-entry to practice for practitioners with suspended license. So one of the goals of the commission is to ensure the patient safety, and then that's why we provide guidance for practitioners that are seeking reinstatement after their license is being suspended. So usually license has been suspended for unprofessional conduct or either they have any mental or physical impairment. So when they want reinstatement, practitioners must not only meet all disciplinary order requirements, but they also should demonstrate that their current medical knowledge and skills, because when you take time away from the practice of medicine, it can lead to your skills to decline. So they also have to go through some formal or informal entry program after the suspension. And I think this is the document that you want to make comment. Is that right? So if you have any comments or feedback on this one, you can raise your hand or use the chat function. The floor is open. Go ahead.
Okay, now I got it right. Thank you,
Mhm.
and hi everyone, and good to see you all here. Has been a long time, and I have some specific comments about this particular policy. I like it because I have been saying this when I was serving on the commission, and now after reading it, and I felt there are a couple of places that I have concerns um, about the wording. One is under the guidance, the first paragraph under guidance. And the text said the commission may require a practitioner with a suspended license to demonstrate clinical competency. I have a concern about this wording may, because I felt, from public perspective, I felt this should be well required a practitioner, by completing a re-entry program prior to interim practice, because your background state well after spend a license being suspended for a period of time, it typically their skill decline over time, their knowledge and skills. So I felt May is a little bit wishy-washy. We can decide here, we can decide there. I feel it should be universally be required. And the second place is in the, my concern is in the second paragraph, is the last sentence in the second paragraph, which is at the very least, reentry programs should including reflective self-assessment. So my concern is about the wording self-assessment. And there have been some well-known studies in the past, in particularly about self-assessment for the incompetent physicians. They are typically not effective, well studied. They're not reliable and flawed because cognitive biases. And so it's in particularly less skilled physicians or providers, professionals, they tend to overestimate their own ability and sometimes least accurate at a self-assessment of their competency, knowledge, and skill. So I would like to see from the public perspective is to say the assessment require some external assessment, like a peer review monitoring for short period of time, direct observation, chart reviews, and performance data to reviewed by peers, and also could including a 360-degree feedback, which would including all peers, nurses, patients, and other health providers that, professionals that have been working as a team with the physician. So I would like to see a reevaluation, not self reassessment, so that would, we would have more confidence about reentry physicians' ability to practice in the best interest of protect the public. So thank you for the opportunity for me to comment.
Thank you so much. And go ahead, the next one.
Rick, you can go ahead.
Oh, okay. Thanks, Fatima. Great to hear from you, Dr. Yu. It's been a long time. And thanks for making those points. If I could address the first one that you had, the commission may require a practitioner. This is someone who's under discipline with us already, right? So they would have an agreed order or stipulation. And the language in there, we do require them to get an assessment in most cases to make sure that they're safe to practice and their skills are current. So I think it's addressed in the particular agreed order or stipulation. And it helps to have this policy so we can point to it ahead of time so that respondents know what they're getting into. And then your second point, at the very least, reentry programs should include, et cetera. We use Acumen and Pine Grove and a couple others that the commission approves of. and they're very robust. And they would, if someone's out of practice more than 2 years, we definitely send them to a place like that.
Thank you, Rich, for the comments.
Yeah, you're welcome.
Thank you so much, everyone. Do we have any hands or any suggestions on this? Okay,
Could
so
I make
we can.
could I make one more comments? And I appreciate I appreciate Rich's comments. I understand being on the commission for 9 years. I understand the commission is really working hard in this situation. Suspended license the physicians, and we try to make sure they are competent to practice. Um, in in my suggestion, I like the policy. I'm mainly trying to point out that it may be a peer reviews among their peer rather than just commission to review in the sanction order that he needed to or she need to comply with this CME or in the order, but the broader peer reviews, including other nurses that the team, including patients, will make a broader records review, make a broader picture of the competency and skills, whether during that suspension period of time that physician have been able to keep it up with a skill to practice safely. So thank you for the comments.
And let's move to the final one, which is the informed consent and said decision making. It's also a guidance document and it's due for review. So as we all know, informed consent is not just a communication or it's not just a signature that the patient give, but is to ensure that the patient understand and then they agree to what is about to be like what procedures or what kind of treatment the doctor is about to do. So it requires them to be completely voluntary. That means they should agree on it without any force, and also it should give the full disclosure of the risks, the benefits, and the alternatives of that treatment or procedure that the doctor is about to do. And also, the patient should understand and they should be in the capacity to make that decision by themselves. And also, we move to the shared decision part, which is about like actively involving in the patient's values and preferences. So they often supported by decision aids. Like let's say a patient is like they give him an alternative of different treatments or different procedures, but then they needed more help to be able to make a decision whether they consent to this treatment or procedure or not. So this also requires the patient to understand exactly what they are consenting to, and this cannot be delegated. Both the said decision making and the informed consent should be done by the practitioner that is seeing the patient. They should not delegate this to any personnel that they're working with. And then also there are exceptions that includes when, like let's say if it is an emergency or it's an involuntary treatment, or when they feel like the disclosure will cause harm to the patient. So we have a whole document on this. If you have any suggestions or comments, you can raise your hand or use the chat function. The floor is open.
No hands or comments, Khadija, too.
Yeah, no problem then. That's all we have for today. And I'm gonna pass it back to you. Like, does anyone have anything to say before I pass it to Fatima? Okay, Fatima, thank you so much. Let me pass it to you back.
Thank you, Khadija, too. This is now the time where interested parties like you can share your thoughts and suggestions on the WMC's policies. We encourage everyone to participate and express their ideas respectfully. If you have an idea for a policy or suggestions to reform an existing policy, please use the raise hand feature within Teams application and you will be called upon when it's your turn to speak. When sharing, please remember the WMC regulates allopathic physicians or MDs and physician assistants. If you have an idea for a different profession, feel free to send it to the email address on the screen and we will forward it to the right place. Thank you. Go ahead, Yanling.
Yeah, thank you. I know the commission, I have a question about future policy direction, in particularly focusing on the practitioner education program. I don't know, I remember if I said right or not, call it the right name, is the one that, during the CMT, if you found some concerns, commission has some concerns, then you made a recommendation for practitioner to get in touch with someone at commission to do some, education or skill improving program. I wonder if a commission, what is commission's thoughts on that? Will there be any policies gonna draft up for this particular one? I'm particularly interested in whether this would have something to definitely define how this would be communicated to the practitioner and to the patients who brought up this complaint or concerns. Thank you.
Go ahead, Micah.
Hi, Dr. Yu. It's Micah Matthews. So we don't have a public-facing policy on this for a couple of reasons. Well, number one, we are trying not to make procedures into policies. So that's the first part, and really the PSP, or the Practitioner Support Program, is really functionally a procedure. So the commissioners get to choose whether that happens, and they can identify the issue. So, like when the commissioners are going through CMT and they choose to either close a case or defer it to a specialist, or choose to investigate it, we don't create a policy for that. That's just a procedure is defined in law on the basics of how we do it, and then we process map it out, so we know how it's supposed to work. With that being said, Gina's on, and she can surely chime in, because she's responsible for the program now. And I realize that you kind of saw the tail end of that program as it started. We still don't have a robust data set about what the outcomes are with that. And so we're still gathering more data as far as sending them out and then investigating what, if anything, happened. So the other aspect is we are working on an ombuds position that is sort of the mirror to the practitioner support, and that position is intended to help patients navigate our processes and allow patients to raise concerns to that ombuds position and be able to sort of have the analog to the practitioner support, but it's more complainant support. Gina?
Yeah. Micah, thanks for the comments.
Hi, Dr. Yu. It's Gina. It's so good to hear your voice.
Yeah, hi, Gina.
Hi. Yes. Right now, we don't have a lot of great data. There have been situations where I have, on a case-by-case basis, depending on the nature of the complaint and the recommended educational activity, I have personalized complainant closure letters a little bit to make complainants aware that um, while the case was closed, the commission did provide some support and recommendations for an educational activity, like I said, on a case by case basis. But um, as we get more data and kind of see where this program is going, um, I I would probably seek public input and work with our policy folks um, to see if we can't come up and also with the obviously with the commission um, come up with another closure letter that might cover these things, but that's really just an idea right now. It's not anything more formal. So that's where we're at, and it's so good to hear from you again.
Yeah, thank you, Gina, and for clarification. And it sounds good. I like your plan. I look forward to hear future what the data will show. And again, thank you, Gina and Micah, for your comments.
We did receive a comment through email regarding the informed consent policy, which is going to be included in the next policy meeting packet. And Micah, go ahead. Thank you.
This is just responding to Jody in the chat, and I would like to ask if Jody could provide us a little bit more context with respect to the roles and responsibilities piece that you're looking for.
Sure. We are seeing some confusion when a resident is admitted to a nursing home that is also receiving opiate treatment regarding the roles and responsibilities of each doctor. Um, there's been significant confusion in more than one facility around prescribing for pain management versus altering prescriptions from a drug treatment facility.
Okay. And this doesn't have anything to do with MAT or anything like that?
No, I don't believe
Okay.
so.
And are these residents that are coming from an acute care hospital or?
Yeah.
Okay. I think there's actually an exemption that relates to that, but I think we could probably take that conversation offline. The other piece to note is we are actively revising those rules right now. And so I would strongly encourage and provides that feedback either through one of the meetings or through our online comment portal, which I'm guessing Amelia is about to provide in the chat. If she's not doing that, there he goes. Yeah, so she provided the exemption, and then we'll put a link to the rules page for the opioid prescribing revision in the chat as well, so you can find that, and whoever needs to attend can sign up.
Great, thank you.
Thank you.
Do we have any other comments? I'm not seeing anything. So this now concludes the WMC Interested Parties meeting. And I'll throw it to you, Khadija, too, if you have any last comments.
I'm sorry, Mama, has got lost. I don't have any. So thank you so much, everyone, for joining us.